I'm Istvan Urban, and I'm here in the Regeneration TV studio with Professor Dr. Khan, who is a professor at Loma Linda University. And for me personally, he was one of my very, very important teachers when I was a student at Loma Linda, and I'm very, very thankful for him for many, many things he taught me. Welcome to Budapest.
Thank you for inviting me, Istvan.
You are a pioneer in many ways, and you're a hero for many of our clinicians and many of us. And basically, one of the most important things you developed was the immediate implant placement. And I remember when I was coming to Loma Linda, you were already doing that, and you were helping me with some of my patients. So how do you feel about that this became so popular?
Well, as you know, immediate implant placement have been very controversial over the years, especially early on. A lot of people are actually quite against it. Even now, there may be some people still against it. So, early on, it was a big struggle because there's a big learning curve at the beginning. There's a lot of things we don't know too, all right? But over the years, we start establishing some guidelines, and I believe now, most people agree that it is absolutely one of the viable treatment options for replacing an anterior missing tooth.
Yeah. Yes, and I think many of the clinicians follow this protocol, but this protocol is still something that you have to take very, very seriously. So what do you think the key elements? What do you recommend for like somebody who just begins this, the key elements to learn?
As we all know, when you compare to putting implant in heel sites, it's much more technique sensitive. And also the foundation bone and the gingiva need to be there. So we need to have enough bone for stabilization. And the biggest concern always have been how to control the buccal contour. But then, of course, now we know we always need to graft the gap, and also in additional grafting outside the gap to either using bone grafting or soft tissue grafting. So, and of course, controlling occlusion is also a very important factor. So for young clinicians, they want to start, they really need to go by the guidelines to make sure everything is correct in order to get good success. Now, once you get experience, you actually can deviate from your comfort zone a little bit, and we talk about sometimes when the buccal bone, is not there. It used to be very important. Now we know with experience we can actually control very good aesthetic results despite the fact without buccal bone too.
What do you think the biggest advantage for the immediate implant placement in not only about the speed of it, but is there any other advantages?
Well, the advantages, in my opinion, is aesthetics. We can talk all we want about comparing in a heel size, raising a flap and comparing to doing flapless immediate. I would tell you that consistently I get much better results with, on an aesthetic standpoint from papillae management, soft tissue management with immediate when you compare it with implant in heel sites.
And some, clinicians, they prefer to extract. Some clinicians wait a little bit. Mm-hmm. Like the burn school,
That's
and
right.
They place an implant and a bone graft.
Mm-hmm.
Some clinicians extract with a socket graft.
Right.
So could you elaborate about the advantages, disadvantages, maybe or even aesthetically, the papilla management, the papilla preservation, and what happens with those?
In general, when we compare, if you look at three methodology, immediate implant placement, the heel sites, and also the early placement, the burn technique. When you compare them, I almost like to group the heel sites and as well as the early implant placement into one group and the immediate implant placement in another group. Why? First of all, as we already talked about, in immediate situation, the initial site need to be really pristine, in good condition. So then we can put implants in. Whereas on heel sites and in early placement, the sites can be somewhat compromised and then we can still proceed later on. But the biggest thing about aesthetics is this. When we talk about immediate tooth replacement, that means put a provisional in there. In general, the weakness, if there's one for immediate, is it usually is good for the papillae, but if there's anything wrong, it's the facial tissue. Now, why good for the papillae? Because right after extraction, we know that it is the tooth that controls the papillae. If the tooth is gone, the papillae usually will shrink back. And therefore, by putting a provisional, right at the same time of implant placement, it helps to protect that papillae.
You basically support it.
That's why support it. But then the facial tissue is another monster there because the buccal bone, even if it's there, after extraction, maybe the bundle bone is gone, the buccal plate usually disappear. But nowadays we know how to control it by using bone grafting, the gap, and like I told you about tissue graft. Now, when you look at delay and early placement, actually the concept is a little bit different. Why? Because first of all, you allow the papillae to collapse. On top of that, a lot of times you raise the flap to do a contour grafting. And the design, what people advocate is they include the papillae. So they retract the papillae again. And we know every time when we raise the papillae, what happens? Potentially you increase the risk of papillae loss too. Now that's one more very important point that we must remember when you compare to immediate, especially with early implant placement. I dare say, if you have a situation like a tooth that's failing, and you analyze it, and you find out that case is not good for immediate implant placement. Why? For example, there's no bone for stabilization. Maybe that's a huge infection, all right? Or the soft tissue doesn't look right. And you tell yourself, well, this is not a good case for immediate implant placement. Then you say, why don't we go early placement? All right, so you extract the tooth, and then you wait for maybe 8 weeks for it to heal, that you re-enter the site. Under that type of situations, I dare say, almost more than 70% of those type of situations, if you try to do early placement, it will not be indicated to. Why? Because 8 weeks after you extract the tooth, when you open up the flap in early placement, what do you see? You still see a big hole. You still see a big socket. In a sense, early placement is almost like a pseudo-immediate implant placement. That's where things stand there. So in general, with immediate tooth replacement, it enhances aesthetics, in my opinion, slightly better than delayed site and early place sites.
So you're saying you were discussing that once you extract a tooth and you're not placing an implant because you're not placing it or because you can't, then you will have some reduction of the papilla. Do you think we can gain it back in case if there is an intact bony peak?
Excellent question. Yes and no. What I'm trying to tell you is this. When we do immediate tooth replacement, it's usually good for the papillae. If there's something wrong, it's the facial tissue. On the other hand, the delay and the early placement side group usually is good for the facial tissue. If there's something wrong, is the papillae. But I'm not saying that every single case, this is always true. What that means is even when you do delay or early placement, a lot of cases actually the papillae is okay because maybe the bone is there, there's no problems. But then the risk of papillae problem is going to be slightly higher with the delay and the early placement group when you compare to the immediate group.
And what I see, that even if the bony peak is there, but you extract and you wait, you still get some shrinkage of the sulcus. The interproximal tissue becomes like facial tissue.
Absolutely.
So you're losing like, I estimate, and tell me if that's correct, I would say you're losing about 30% of the papilla.
You are absolutely correct.
Is that 30% if I want to get back? What do I have to do? I have a support of the bony peak. Can I get it with some tissue grafting?
This is a great question to ask. And then, thank you for inviting me to speak this morning. And actually, that's actually what I'm going to bring and talk about. But just to give you a little preview, all right, in general, whether we can gain back that 35% or not depends on a few factors. Depends on your prosthetics, emergence profile, depending on the soft tissue thickness, that is providing if the bone, there's no interproximal bone loss. In the most ideal situation, if the papillae got shrink back, there's no interproximal bone loss with soft tissue grafting to thicken up the soft tissue, as well as proper prosthetic emergence profile, good chance you can gain back that 35%.
And are you going to get it back at the beginning or at the, like before even temporization, or during the temporization, or later?
Okay, that's a great question. To be honest, once the papillae is collapsed, it doesn't matter whether when you put an implant in, whether you put a professional in, or when you put an implant in, wait for it to heal, then 6 months later put a restoration in. When you compare papillae have been collapsed, regardless, immediate provisionalization in heal sites or put the restoration in later on, the final destination on the papillae in the end is almost the same.
Thank you.
You're welcome.
So let's talk a little bit about thin versus thicker phenotype or biotype. So if, let's say, I'm putting in, I'm extracting a lateral incisor, which is not a big tooth, and it's a thin, fragile biotype with a highly scalloped tissue, I want to preserve the papilla. To me, it will be very important. And I'm putting in the implant. So what do I have to be aware of? It's a thin biotype. What size of a gap do I need to say that I can do this without contouring the outside of the facial bone, or can I safely place an implant and just put a bone graft in the socket, even despite it's a thin biotype?
Okay, so first of all, thin biotype. How do we define? Well, actually, the term is phenotype. All right?
Phenotype.
Biotype, people may,
Yeah, that's why I
not
said
agree with that.
phenotype or biotype.
Yes. So when we talk about thin phenotype situation, once we make the diagnosis, we know that's a situation there. What we do is, of course, regardless thick or thin, we always put the implant in the same position. That means set the implant back. Ideally nowadays to leave a gap of minimally 1.5 millimeters between the implant and the buccal bone. Of course, fill the gap with graft material. Now, what type of graft material? In general, we did a study comparing using xenograft versus autologous bone versus allograft into the gap alone.
That's very interesting.
And look at how much the contour collapsed in. Well, not surprisingly, the xenograft group obviously collapsed the least amount, okay, when compared to the allograft and the autologous graft. Now, is it significant? Not that much there. Regardless, so implants are always in the right position, leave a gap, graft the gap. Ideally is to use xenograft small particles. Now, how do we counteract the thin phenotype situation? In my opinion, I will always do connective tissue graft, either through a tunneling technique or you raise the flap just like what Kelly does. Either way, you will usually get a pretty good result. The goal is to try to so-called convert the phenotype from thin to thick. That's how I will manage it nowadays.
And if you have a little bit, moderate, or severe facial bone loss, the soft tissue looks very good. And can we place immediate an implant? And if yes, what do you recommend? And do you have any guidelines?
Okay, great question. As we mentioned before, buccal bone is very important when we do immediate implant placement. Nowadays, it's not important anymore. So what are the guidelines? Rule number one is we need to look at the size of the defect. How wide is it? Because when we look at the width of the defect, a publication that was published more than 10 years ago, they look at when they do immediate implant placement with different width of the defects, how would that affect the aesthetic outcome? The authors in that article find that if the defect encompasses the bone of the adjacent teeth, that means there's interproximal bone loss. Now, that type of scenario, things get very dangerous because when you do immediate implant placement, great chance of significant facial tissue recession. So, in other words, if the facial defect is narrow, as long as it doesn't encompass adjacent teeth, we can proceed with immediate implant placement. So that's one rule. Rule number two is that despite the defect, we must have enough bone for implant stabilization, usually at the palatal region of the socket or the apex. Rule number three, for if no buccal bone, if you look at the socket occlusally from an incisal view, you want to make sure that if you put an implant in, that implant needs to be within that occlusal bony socket, despite the buccal bone loss. We found that under such circumstances, if we follow this rule here, and after immediate implant placement, by doing both bone grafting and tissue graft, maybe with immediate provisionalization, we typically get very, very good results with very minimal to non-recession.
And in these cases, are you doing the bone graft still flapless through a tunnel, or you raise a flap and you graft into the socket and outside of the socket?
And that's another excellent question there. To flap or not to flap? All right. In general, we've done both flap and flapless situations. But what we notice is a lot of times, if there's a buccal defect, usually the defect is caused by pathology. All right, some sort of pathology. And what we notice that if we do flapless procedure, despite the fact that we curettage the socket, we find out that actually there's a lot of times granulation tissues that adhere to the soft tissue that we cannot clean, and we don't even know that. Now, will that create a problem? Nobody knows. So where do I stand? In general, I'm not being uncomfortable. If there's a buccal defect, I do a flapless procedure. However, if that buccal defect is quite severe, and I know that the infection was quite severe beforehand, under such circumstances, I will not hesitate to raise a full flap to make sure I clean out all the residual infection prior to implant placement.
And then, of course, we start to think about now, okay, let's say I'm going to place an implant. There is a facial bone defect, and I want to manage it, and I want to raise a flap to make sure that I will have good bone and good soft tissue. And I might even had a little bit of a recession, so I may even want to mobilize the tissue a bit more coronary. So then you start to think about flap designs.
Yes.
And then, okay, what kind of flap designs can we think of?
Okay, good question. When we talk about flap design, usually, every time when I raise a flap in the aesthetic zone, my main concern is the papilla. All right? Because we know every time when you raise a flap, there's a slight chance that papillae may get shortened. Even the bony peak is good. So what I do is this. Before I even raise a flap, I always do periodontal probing as well as bone sounding at the interproximal area. Number one, to ascertain that, making sure that the bone to the papillae relationship is good. Now, if this is good, I have a little less hesitant to raise the flap, including the papillae. However, if the bone is compromised, I will try to stay away from touching that papillae for sure. So how do we make that incision? Providing if I do not need to coronally advance the flap, what I'll do is I'll just do a single, almost like a coronally advanced flap incision design. That means I'm not going to extend my flap to the adjacent teeth at all.
Like for a single recession.
Just like a single recession situation. That means I'll make the incision towards the line angle of the adjacent teeth. That means the mesial line angle of the adjacent teeth there. And then what we can do is we can just do a papillae horizontal incision shy of the papillae. By doing that, that is if we don't need to coronal advance. Now, if I need to coronal advance, I'll probably, once again, same incision design at the line angles of the adjacent teeth, the mesial line angle of adjacent teeth, and then I'll include the papillae there.
You deepitalize maybe and pull it down.
And then pull it down, yes.
Thank you very much.
You're welcome.
Now, let's step back for the immediate implant placement. Let's say I am not so experienced, and I just extracted a tooth and I placed an implant. And everything went very well. But I am not sure if the stability of this implant, which is stable. So what would be the guideline that you would say that in an average occlusion situation, when you don't have like traumatic occlusion, how much stability do we need for the implant to be able to place a provisional?
Well, there are two ways to quantify stability.
Yes.
Scientifically. One is go by certain insertion torque. People usually recommend 35 Newton centimeters. That's what you always hear about.
And what do you recommend?
All right. Well, for me, I'm comfortable, even if it goes down to around 20 Newton centimeters, in my hands, is fine. All right. But anything less than that, I start feeling a little bit uncomfortable, even in a normal occlusion situation. The second method that people use to quantify stability is using the ISQ method, all right? The resonance frequency machines there.
Right.
So they always say that 35 Newton centimeters is approximately 63, 64 ISQ or so. So, as a young clinician, you can either use one of those methods, but in my opinion, basically following the insertion torque is more than enough. So beginners, I would say that let's try to stay, within 30 or above Newton centimeters. But again, in my hands, all right, as long as I can control occlusion, anything above 20 Newton centimeters is a lot. All right? And then, we almost never have any problems with anything 20 or above.
And if you would say, if let's say I'm placing an implant and I get 15, and I'm not comfortable and I'm afraid, and I don't want to put a provisional. And I had a case like that as a resident, and you were with me.
Right.
And you were building a customized healing abutment, maybe one of the first in the world. It was in '99. And that was the purpose, was that to freeze the papilla, basically.
That's right.
So is that what you still recommend? Let's say I cannot put a temporary crown. Would you recommend to do that?
Absolutely, that's what I recommend. Again, using what we call customized healing abutment, which is very easy to do. Anytime when an implant or less than 50 Newton centimeters, in which you can literally use your hand to turn
To
it,
rotate.
it's probably better to go that direction. Now, but the thing is this, when we talk about stability, there's two ways to quantify stability. It's not just as simple as how much insertion torque and so forth, because there's that rotational instability, and then there's that,
Wobbling.
Now, wobbling is a really bad thing. For me, when I see something wobbling, I usually will remove the implant, either graft the site or place a different size implants and restart the situation.
Very good. So a couple of millimeters, you plan the implant longer than the apex of the socket, if there is bone.
Okay, well,
How many millimeters?
Well, actually, traditionally, if you read the literature, the authors usually describe in immediate situation, they look for two areas in a socket to achieve stabilization. One is apical to the root tip socket, and they always ask for around 4 to 5 millimeters. The second area is typically palatal to the socket there. Now, the reality is this, if you look at it nowadays, most of the time, bone apical to the socket is not as important because usually the implant will be placed palatal to that area. Now, of course, it's still, if you look at it, although in a different plane, still it will be apical to the socket there. So in general, what we want to define is this. When we look at, let's say, a CT scan, when we do immediate implant placement, there's no science to quantify that, but minimally, we should have at least 35% or greater of the implant being encased in bone when we do immediate implant placement, and providing with at least 30 or 35 Newton centimeters to ascertain success.
Thank you. One more question.
Sure.
In case of a traumatic occlusion, or an occlusion which is maybe dangerous for it. You have a very good implant. You did everything perfectly. You are very stable. You have a perfect provisional. Do you ever give the patient like a night guard, a splint that will guide away a potential traumatic experience during the sleep?
Absolutely. Well, let me tell you, in my career, I have just a very few, immediate implant placement situation with provisionalization that failed. And usually they are on patients who bruxes. So a lot of times just taking that provision out of occlusion for those group of patients is simply not enough. Now, so we either, if you identify that we have patients like that, you either go in there and forget the provisional and go with the customized healing abutment that we talk about, or if you really feel that you got to put the provision in there, like you said, absolutely got to put some sort of protective night guard in there and make sure the patient wear it to minimize problems.
And you put it to which jaw? The top jaw or the...
Well, for me, usually I put it on the top jaw, okay? I just hollow out the provisionals there, yeah. Okay.
Thank you so much. That was very, very informative. And I really think that this was also learning. Thank you so much.
No, thank you, Istvan. Thank you
very much.